It's time for episode 3. This is your host, Dr. Boyes Kakiani, a prosthodontist from India, and I welcome you to this webinar, which is titled Verifying and Recording Centric Relation. Now, friends, I left you in episode 2 with a brief introduction on the Dawson Manipulation concept, which is a protocol that is used to determine the centric relation without the use of an anterior deprogrammer. Now, what is Dawson manipulation all about? It is about using all 10 fingers to allow the mandible to go into a position of complete relaxation. Dawson, who himself designed this technique, speaks about romancing the mandible when you are performing this procedure, which means it is an extremely delicate procedure. It's important that we apply no force when we are trying the Dawson manipulation technique. Friends, the technique begins by first using both your little fingers to palpate the angle of the mandible. Once you have located that, you position your little finger slightly behind the angle, and you then bring all the other fingers such that they are placed on the inferior border of the mandible around the area where the masseter muscle attaches. Once all your 8 fingers are in position, you now bring your thumbs in and hold them on the symphysis area to create what I love to call the owl eye effect. It's just like how the owl has 2 lovely big eyes centered there. It kind of creates that pattern. Have a look at the picture on the left. Now, once you have achieved this position, I start to hinge the mandible a little without applying much force from my thumbs. Now, when I'm doing that, once again, it's very, very, very important that this be done in a very, very gentle, relaxed manner. Have a look at this quick video. See the small hinging strokes that are allowing the mandible to move very, very freely? Now, once I have achieved a position like this, I am repetitively telling my patient, completely relax. Relax the shoulder, relax the jaw. I often even tell my patients, close your eyes. Imagine you are in a beautiful place and completely relax. The tone and pitch in what I speak to my patients with also is a very, very relaxing one. Once again, please do not force the mandible at this point of time. Do not do rapid jerky motions. You do that, your muscles will in fact get activated. Once you have achieved the hinging, in my head, I am thinking my patient has gone into centric relation because the musculature is completely relaxed. This may not be the case. Mandible hinging actually means you have achieved neuromuscular relaxation, but this is not guarantee that you are in centric relation. The only way you can be certain of centric relation is a procedure called as load testing, and this is a continuation of the Dawson manipulation. What does load testing entail? Once I have achieved a position of neuromuscular release, I now start applying a little bit of upward force at the back. As you can see, there are orange arrows facing upwards from all 4 fingers at the back and a downward movement at the thumb. This creates like a torque effect and it positions the mandible into its centric relation position. This is the first time when I begin to apply a mild amount of force. Next, I increase the vector of force. This is the brown arrows. And last, I go up to an even firmer amount of pressure that is applied through the condylar region, which is here designated by the red arrows. Now, what is the thought process when it comes to load testing? Now remember, the disc is a non-innervated piece of tissue, which means it has no nerve supply, which means no matter how much force I apply through the tissue, my patient should not have any symptoms around the condylar region. Now, the position of the fingers that are in contact with soft tissue, my patient may feel discomfort because I'm actually physically exerting pressure. But the patient should feel no discomfort around the condylar region. Let me explain all these three to you individually. Once again, once I have achieved neuromuscular release, I start with the first increment of load testing, which involves a very mild amount of upward and forward force. If with little bit of force application, my patient tells me, "Doc, ow, it hurts," my diagnosis immediately is active temporomandibular joint disorder. Look at this particular area. See how the disc has been displaced forward and the condyle is now loading retrodiscal tissue? Remember, retrodiscal tissue has a lot of nerve supply. So the slightest bit of force and my patient is going to jump in pain. Response to a mild amount of pressure is diagnosis for a true temporomandibular joint disorder. If I have applied mild force and my patient does not complain of any tension or tenderness, remember we never talk about pain right now, we're talking tension and tenderness in the joint area, I will increase the vector of force to a moderate amount. Once I have increased the force, and if my patient now tells me that the patient feels tension or tenderness in the joint area, my diagnosis is this is possibly a healing joint, or this is a joint which has a lot of spasm in the attached musculature. Now imagine a scenario, I apply moderate force and my patient still does not complain of any tension or tenderness. I will now take this to a firm amount of compressive load, which means I'm genuinely applying a lot of force pushing through the condylar region. At this point, if my patient tells me, "Doc, I feel a little bit of tension or tenderness on one side," this could be one side, this could be both sides, my diagnosis is the lateral pterygoid muscle is still in a spasmodic contraction, which means it is still protecting the joint. It means the condyles have still not gone into a centric relation position. This is the concept of load testing, which is a compulsory clinical step to verify whether your patient has gone into the correct centric relation position or not. Let me now break your bubble and tell you this is easier said than done. Understanding the direction of force, understanding the amount of force, it is a very, very subjective matter. Often people tend to apply too much force or apply it too early in the process, which means you may get false positive or false negative results. What do I do in order to teach people and attempt to overcome this subjective issue? I tell them, why not do load test with an anterior deprogrammer in position? How is that possible? With the deprogrammer position, remember only the lower incisors are contacting. So what do I now tell my patient to do? I tell my patient to clench down on this as hard as possible, which means whatever musculature is still active in an edge-to-edge position will now bring about a movement of force. If you remember reading trajectories of force, the force from that point of contact around the lower incisor travels through the body of the mandible, around the angle, into the condyle, going straight into the disc. Once again, the forces go in a very definite manner and dissipate into the disc. If I need to, I will now put my fingers into bimanual manipulation, or Dawson manipulation as it is famously called, and increase the force vector at the back. What am I trying to do? I am trying to identify if my patient shows any symptomatic response, tension or tenderness around the condylar region. If my patient says, yes, doc, I do feel a little bit here around the condyle in front of the ear, my thought process is load test for this patient is positive. Patient has responded to tension or tenderness, load test is positive. Because load test is positive, I have not achieved centric relation. Because I have not achieved centric relation, I will not record the centric relation bite. What will I do? I will tell this patient to wear the deprogrammer for a longer period of time. This is where the concept of short, intermediate, and long deprogrammation comes in. When will I record centric relation? Once my patient gives me a negative response to firm pressure, which means load test is negative. I am certain in my head both the condyles have gone into centric relation. I now go ahead with recording a centric relation bite. Now, in an attempt to do that, I have two material options available with me to choose from. First is a bite registration wax, and a second is a bite registration addition silicone paste. Let's look at the first one. That's your bite registration wax. What I would love to use is a Delar wax. This is a wax that is available from Whipmix, but unfortunately not available in my country very easily. So what do I use instead? I instead use an aluminium reinforced block of wax, which is called as Bital. It comes in a 7mm homogeneous block, which means I don't get separation of sheets, because that is what we used to earlier do. We used to take bite registration wax and stack sheets up together so that I can get a thicker block. Now, why do I need a thicker block? Because when I am recording my centric relation, I do this with the anterior deprogrammer in place. Like you see here, the unwind is in the patient's mouth, and I am using Bital to record the centric relation at an increased vertical dimension. This is how I normally record centric relation for my patients. I also have the option of using a bite registration paste. For this, a brilliant material is Futar D. Again, not very easily available in India. So what we frequently use here is an imprint bite material, which is from 3M. The concept does not change. I still am using an anterior deprogrammer. However, I am just registering the bite not with wax, but with a bite registration paste. You go ahead and cut the paste to make sure that the material does not extend beyond the occlusal table. Now, if you were to ask me what do I prefer, wax or paste, I will always tell you that I want to be absolutely sure that my mounting is correct. And I am more confident of my mounting if I have a block of wax that is giving me cross arch stabilization at the time of mounting, and not two tiny little pieces that may be a little clumsy, and I might lose the accuracy of my record by not transferring it to the articulator correctly. Now, yes, I know you are wondering, how do we do the actual mounting? So here, I close episode 3 by inviting you to come and watch episode 4, which is going to be exactly 1 week from now, and it is on mounting of casts on a semi-adjustable articulator. Once again, if you enjoyed this video, please like it, please share it with your friends, do share your comments, do subscribe to the channel and watch this space for more. I once again wish you a happy week ahead. We shall fight through this virus. Let's stay at home. Bye-bye.